I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves. I have realized that we have had so many successful people on the fertility journey through Love and Science, and we have not really shared stories. And I think, this is National Infertility Awareness Week. One of the hardest parts about the journey is feeling so alone and feeling like it's never going to work. And so I am going to share de-identified stories with you to understand the kinds of ways that we help people and the kind of success stories that are possible. All right, let's dig in. So I had my very first client who came to me saying that she thought IVF was going to be the solution to her problems. And unfortunately, she still had not been successful. So I will say most of my clients have done IVF, it's not working, and they're really starting to get threatened with not being a parent. So she had already had 2 losses before IVF. She had actually generated several euploid embryos, thankfully, and came to me having a diagnosis of a prior fibroid, which had been removed, adenomyosis, and recurrent pregnancy loss. She thought, getting to the euploid embryos is going to be the thing that will fix everything. But unfortunately, her first transfer ended in a miscarriage, and her second transfer, she was not pregnant. She joined Love and Science. She coached for 3 months while she was doing her loop run, actually, because they were trying to suppress the adenomyosis. And her next frozen embryo transfer, which was about 6 weeks into the program, it was successful. And now she has a child. And so, I think that that's a story to say that I think it's really disheartening when IVF is not working. And it's like, oh, I just have to do the most aggressive thing. I have to do the most successful thing. But when the science isn't working, it can be very terrifying. And so, she said to me, she was like, I'm concerned that IVF is not going to work for me. And I'm also concerned that I'm blocking my own chance of success because I truly don't believe it's possible at this point. So we worked together, very, very closely to help her uncover her limiting beliefs. We helped to challenge the idea that it wasn't possible, and we just cracked open the door to possibility. I remember seeing her energy shift, and, again, I remember seeing her on the Zoom call, and I was like, oh my goodness, this transfer is going to work, because I knew it, because I knew she was ready, and everything was aligned scientifically. And so if you're in that space where, say you have embryos, or say you've got a treatment plan, and your body is just so shut down because of obviously self-protection, right? It's like, how could this ever work for me? Or I don't even want to hope because I've just gotten so much bad news in the past. Love and Science really is for you, because we make sure the science is sound, and then we work on the emotional piece of it to improve the physiology, to be open to successful outcomes. And what I do is I bridge people to parenthood. So wanted to share that story. Thanks for listening, and support is yours if you'd like it. I love you. Bye. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about an actually fairly controversial topic, which is the thyroid and reproduction. I love talking about this topic. I've actually given grand rounds numerous times on this topic. And the interesting thing is that it keeps evolving. So I think, back in the day when I was still a kid, actually, we got pretty concerned about the thyroid and reproduction. There were some studies, actually a frequently quoted study in the New England Journal of Medicine, that suggested that if the thyroid was not well controlled, that offspring would have really bad sort of neurodevelopmental delay. Obviously, we all want to avoid that if possible. And so I think the pendulum then swung to getting really, really stringent about the thyroid, to the point where when I was a fellow, we checked the TSH on every single person. And even with a subclinical hypothyroidism, which means that the TSH is in the slightly elevated range and the free T4 is normal, that we would really, really freak out and start aggressively treating. And then our patients would get jittery and palpitations because we were overtreating them with levothyroxine. And it was something that I actually got very nervous about going into my oral boards, because I didn't think there was a ton of evidence to be doing that, but it was like all over my case list. Anyway, I will say that recently the American Society of Reproductive Medicine has released a new guideline, which I want to review, because I think that we always need to strive to be evidence-based. And when they did a thorough review of the literature, they actually did not find compelling evidence to be screening everybody and to be treating everyone. And again, from a very evidence-based lens, I want to talk about when we should be screening, when we should not be screening, when we should be treating, when we should be checking antibodies, and what the data actually show. So how do we even define hypothyroidism, right? In this document, they're talking about subclinical hypothyroidism in general. And again, this is a very recent document. It is from Fertility and Sterility in 2024. So they define subclinical hypothyroidism as a normal free C4 and an elevated TSH. And let me share with that basically depends on in your reference range, the TSH that is above the upper limit of normal. And if that does not exist, they use the level of 4.12. And so, and that's milli international units per liter. So some caveats, right? People have to live in an iodine sufficient area for this to count. Basically, the levels have to be stable for a few weeks, and also the patient should not be ill. The next question is whether subclinical hypothyroidism is related to miscarriage. And I'll read from the summary statement. They say there is moderate evidence on the basis of intermediate and low quality studies with some contradictory findings that subclinical hypothyroidism during pregnancy is not associated with an increased risk of miscarriage. Most intermediate quality studies do not show an increased risk. There is moderate evidence that TSH levels between 2.5 and 4.0 milli international units per liter are not associated with miscarriage. So I think that's really important because we used to use the 2.5 level like very, very absolutely. And now if I see somebody their TSH is like 3.3, I'm much less likely to, go after that based on this, information. And we'll talk about some caveats, but I think in general to say that an elevated TSH is not associated with miscarriage, I think that's really important information to have. And most of the data point in that direction, right? Okay, the next question is untreated subclinical hypothyroidism associated with infertility? Interestingly, there is weak evidence that subclinical hypothyroidism is not associated with an increased risk of infertility. And so I think it's, a little bit tricky because what do we do with weak evidence? Well, we have to look at more and more of the data. And they go through the studies in their article, but I think we have to be very intentional. So, thinking about our next question, which is subclinical hypothyroidism related to worse neurodevelopmental outcomes in offspring? And they say that there's moderate quality evidence that subclinical hypothyroidism during pregnancy is not associated with adverse obstetrical outcomes and neurodevelopmental, issues as well. And so I think if we used to use 2.5 as the cutoff, and now they're suggesting 4.12 or the upper limit of the reference range, for people in that age range, then I think we have to be thinking about that, with a lot more clarity and discernment. Then the question becomes, does treatment of subclinical hypothyroidism actually improve outcomes? And they looked at, all the different things like miscarriage rates, live birth rates, clinical pregnancy rates. Interestingly, they say that there is moderate evidence that treatment of subclinical hypothyroidism with levothyroxine does not improve pregnancy loss, clinical pregnancy, or live birth. So that's really interesting, right? A lot of this levothyroxine is probably chasing our tails. And I think we need to stop it, especially if it's been our practice up until now. And I think it also makes it easier on the OBs because OBs and MFMs for years were saying, listen, we inherit these patients. We don't really know what to do with it. We don't think it's evidence-based. And I think, obviously, if it were evidence-based, it would be a reason to continue that. But I think if we can adhere to the guidelines here, we're going to, sort of make a lot of things more simple as it comes to not just getting pregnant, but staying pregnant and managing this throughout the pregnancy. Okay, next question is about thyroid antibodies. Are they associated with infertility or adverse reproductive outcomes? They say there is strong evidence on the basis of 3 randomized clinical trials that levothyroxine therapy for women with subclinical hypothyroidism diagnosed in pregnancy has no benefit for obstetrical, neonatal, childhood IQ, or neurodevelopmental outcomes. So I think that's really interesting, right? So like treating does not seem to make a difference. Okay, next question. The question of whether antithyroid antibodies are associated with worse outcomes, they say there is intermediate quality and conflicting evidence that is insufficient to suggest an association between thyroid antibodies and miscarriage. there is weak evidence that women with recurrent pregnancy loss have higher rates of positive thyroid antibodies on the basis of limited case control studies. And there is insufficient evidence to recommend screening for thyroid antibodies in infertile or pregnant women. So, interestingly, how I interpret this is that if I have a patient who has recurrent pregnancy loss, um, and we're really trying to test everything, it may make sense to screen that person for antithyroid antibodies. If somebody has a, big history of autoimmunity in their family, and they also have infertility and they're worried, or maybe their TSH is on the borderline. I mean, I think all of these things have to be in a case by case, interpreted on a case by case basis. But I think looking at whether it makes sense to routinely screen women for antithyroid antibodies. I mean, certainly if they have primary ovarian insufficiency, that's a whole different, category. But if it is truly, typical infertility or pregnancy, we don't generally screen. Truly, I still do screen my patients with recurrent pregnancy loss because if you can find that somebody does have antibodies and you can really work to get their TSH down, we have different cutoffs in those populations. Generally, I like the TSH to be under 2.5 still in that population based on data. That's when I screen for antithyroid antibodies. So if you're listening to this and you are, thinking about getting your TSH checked, or maybe you've been having your doctor check it every 3 to 6 months and you're trying to get pregnant, look at the data and really think about, okay, does this apply to me? Am I increasing my own anxiety, or, is there something real here? Now, I say this with the caveat, and we can, harken back to my episode with Dr. Dana Gibbs, who is an ENT who now really mostly manages thyroid hormones in her practice. And she is a specialist who sees the people for whom typical testing is not revealing. And I've actually sent patients and clients to her when things make sense. If you read the ASRM document, it talks about symptoms. If somebody is completely asymptomatic, there is no need to screen those people. And infertility does not count as a symptom. But if somebody is symptomatic, and I think that gets kind of gray because a lot of the symptoms of hypothyroidism are very vague and nonspecific, but like fatigue, hair changes, nail changes, skin changes, cold intolerance, menstrual abnormalities, right? So anybody with abnormal menses should get screened as well. Like if somebody is symptomatic, then we need to start screening, and we might find overt hypothyroidism for them. Also, if somebody is having a lot of symptoms of thyroid dysfunction and their thyroid tests are normal, it may make sense to go to somebody who really understands, the ratios and the reverse T3 and all the different things that I do believe that there's a subset of people who are, living their lives and they have hypothyroidism, their labs aren't showing it, and that you really do need to go to somebody with that nuanced view. But in the absence of symptoms, this document clearly says there's no need to screen or treat as long as things are still, in the subclinical hypothyroidism category. Of course, if somebody has overt hypothyroidism, we need to treat that. If somebody has persistent symptoms and their labs are normal, we got to look at that. If somebody has recurrent pregnancy loss and we're trying to understand why, and we understand that there may be an association between antithyroid antibodies and miscarriage, then we got to look at that too. But I think, hopefully this will make our lives and our jobs more clear as we go to counsel patients, because I think sometimes in REI especially, we can, do some micromanaging. We can, try to fix what we can. And I think it's all very well meaning, but sometimes it creates more problems. And so hopefully this is a framework for looking at things to say, okay, let's follow the guidelines. Sure, do a TSH if you're feeling tired, who isn't feeling tired, maybe some weight gain, who hasn't gained weight during IVF and all those things. But if those values are normal, then maybe say, okay, it's probably not the thyroid, and we can move on to other things. So I hope you found this useful. You know how much I love you. Bye.